let's turn on to some questions about reimbursement. And Mary, do you see any differences between using 2, 3, or 4 drugs in the patient population or insurance coverage from your perspective?
So that's something that we're just really beginning to track. So I don't really have an answer for you there, but certainly insurance coverage is a major, in some cases for some patients, a major determinant in which therapies they'll be taking, depending on cost.
It's probably easier for them if they are IV or subcutaneous as opposed to, because the oral therapies are where the problem seems to emerge. Right?
Correct. So, and many patients watch that very carefully and make sure that what they're going to be given from their doctor is something that is covered, because they really don't have any choice, and they don't want to have to choose between, paying other bills and taking their medication.
Mm-hmm. Raphael, you talked earlier about the value equation of the expense over time versus savings downstream. Do you want to just recap that for us again?
Sure. So I think when we do analysis of the economic implications of treatments, one has to again consider the whole equation, the drugs, office visits, diagnostic tests, hospitalizations, etc. And I think we have a paucity of data in that regard. I've been working on a number of projects, most recently on one that actually asked the question, what is the cost of recurrence? And what we find actually is that it's cheaper to stay in remission even if you're on treatment than to have a recurrence. Now that might say, well, wait a minute, what happens long term? If to be incredibly cynical, one might say, well, the longer you live, the more expense you incur on a payer. But that's not always necessarily the case. So there's value in disease control. So I think we all need to pay attention. At the end of the day, in the world, resources are scarce and people have to prioritize, and there's going to be trade-offs. But I think as of now, as I mentioned before, we don't have the answers on how to best gauge that value. And there's all the imponderables that come into the value equation, like being able to be present in a wedding, see a grandkid be born. And another factor which is key, which is really fundamental, is what economists call the value of options. And this is very important. This is the ability that you have that by living longer, you can realize the benefits of current research. And that was best exemplified with the HIV/AIDS epidemics, where people who were able to stay on AZT ultimately saw highly active antiretroviral therapy, and many of them are still alive today, versus those that couldn't or wouldn't respond, then oftentimes ended up succumbing to their disease.
Of course, the value to the society if you're back in the workforce.
As well, too.
Now, some of these groups, ICER is one of the groups in the US, NICE in the UK, are using sort of formal metrics for years saved and for dollar value. And what do you think of all of that, Andres?
There are helpful tools which potentially can guide us to making our assessments of value of the regimen versus potential gains and losses, financial losses. So I look at them as a tool to collect more information.
Should we do economic analysis prospectively in all of our trials?
I think we should. I'm very absolutely in agreement with that. But I would like maybe to loop in here something which I haven't heard a lot, but it's a good panel to maybe potentially bounce off you. So I think in the process there is emergence of gap, in my opinion, what expert in the field would have done and what the system or payers will allowing us to do. There was a time a few years ago, not long ago, that if a peer would ask me, for example, what I would do and I would make my arguments, that would be usually listened to. That kind of got lost. So I think we need to think about that there is this field is so quickly emerging, the cost area in particular, that we need to keep more decision-making in hands of people who know more about what potentially can be beneficial as it is emerging with data and allowing us to do some of those things which are eventually exactly in line with what Raphael just said, that it is maybe a value to not to give a more expensive drug right now, but then you're going to lose later. And if they hear it from us, then maybe that will be potentially helpful to the patient.
Thank you. Mary, the MMRF has got quite involved in, with Harvard Business School and other people. How much are you looking at the economics of care, or is that not something you've been tackling so far?
So we've been really more looking at the direct-to-patient aspect of care. So really making sure that patients know that education and their own education in their disease and the way that they interact with their care teams is very important for their outcomes. And we've been, our particular area of that, the Precision Medicine Initiative, has not been that involved with the reimbursement aspect.
Do you think you should be more?
I mean, I think that there's definitely a lot of questions. It's a very complicated area, and a lot of people spend a lot of time working on it. It's a very resource-intensive effort, and in some ways, there are some other nonprofit organizations in the myeloma field that are a little bit better equipped to move in that direction than the MMRF.
Mm-hmm. Some of our colleagues in oncology, both solid tumor and now increasingly hematology, are pretty vocal that they feel the prices are too high and there should be attempts to rein them in somewhat. Any reaction to that, Raphael?
Yes, well, let me start by saying I think we have incredibly smart and passionate colleagues who feel that way. I just don't think they have the complete assessment of the situation. And, we've had vocal and open conversations about this. I think the desire is, of course, to make things the most economically possible, but it's not always possible that things are going to be at the aspirational price that would make it available, not only here, but in the rest of the world, right? But we live in the real world, and that can happen. So I'm going to use the example of ICER. I cannot comment broadly about ICER, but I did look very, very carefully at the ICER analysis. In fact, I watched the 5-hour video of the meeting for ICER, and I would suggest that there's serious limitations on how some of this value analysis are conducted, such that their application for myeloma care, in my mind, would be very short-sighted and not consistent with best practices. In fact, if you look at the report that was done, I believe this is now a couple of years ago, one of their conclusions was that some of the best value would come from the use of panovenostat, a drug that is no longer owned by the parent company, has been sold to a secondary company, which we really didn't use in practice. There's nothing wrong with the precepts that go into how the analysis is done, but the assumptions and the lack of expertise in the panel, I think, was quite evident at the time those conclusions came about. So I think we should have panels, we should have groups, and maybe ICER, but it needs to be in a way that also includes a very, very deep participation from experts in the field.
My sense is in the United States, though, we've been very fortunate, and do you feel that payers and physicians are on the same page, or do you think there's from the patient perspective, is there too much back and forth? How are patients feeling about that? Maybe they don't even see it.
Well, they do. Patients, they do see it. And some patients have discussions with their doctors regarding, I can get this therapy to you for a decreased cost, and this one I can't get due to insurance coverage. And there's many doctors that are conflicted about that, what kinds of therapies they can give to their myeloma patients based on cost. And patients do hear that argument, so they are concerned about it.
Andre?
Well, I think that my biggest frustration at this point is that decision about to go, no go for certain treatment at this point has been very much put into almost administrative kind of a check the boxes list of things allowed or not allowed. That we lost this opportunity for an expert to make a case. I don't have any problems being challenged. Why would you use this? Do you have evidence for that? But if I make an argument and I provide data which is sufficient, in my opinion, that you guys would agree with me and many of my colleagues would agree with me, I don't think it's the right development in what we have. That person who is on the other side would either tell me, well, I actually agree with you, but I am not in the power to really do anything about it, go to the higher level, and then I know how it ends.
The only place I've really found challenges actually in PET scanning. Is the one I get the most pushback
Yes.
on, which always strikes me as rather ridiculous. But
Okay.
well, we are blessed in the United States with great access to drugs so far. I think the economic clouds are darkening in terms of as the costs rise. Obviously, more scrutiny and more oversight, I think, is somewhat inevitable. But I do think we probably would all agree if we can find cheaper, shorter alternatives, that would be ideal. But for now, we're going to do the best we can for our
Certainly.
patients.
And I mean, this is not in any way a problem that's limited to myeloma.
No. But while myeloma has become a bit of a poster child for it,
It has, because of the cost of some of these
for
therapies,
expensive
right?
new drugs, right?
Yeah.